Hey everyone, and welcome. I am so thrilled you're joining me for this explainer. Today, we're going to dive right into something that is honestly pretty fascinating: how a clinician's very own physical senses actually act as the ultimate medical toolkit. We're going to demystify the art and the science of the physical assessment. Here's our roadmap for today. We'll start with the assessment toolkit, then move through our techniques one by one: inspection, palpation, percussion, and auscultation. Finally, we'll wrap up with documenting your findings.
All right, let's get into Section 1, the Assessment Toolkit.
Okay, so before we can really lean on our physical senses, we have to gather our actual physical tools, right? From pen lights to thermometers, scales to stethoscopes, getting all this gear together is step one for performing your general survey. These tools are absolutely essential for obtaining that critical baseline data, like height, weight, and vital signs, which is ultimately going to direct the rest of your assessment. Let's look at a classic example of using these tools to capture a vital baseline: blood pressure. The mechanics here are pretty precise. First, you get the patient's arm resting right at heart level. Next, you inflate the cuff while feeling for the pulse. When that pulse disappears, you pump it about 30 millimeters of mercury higher. Then, release the valve nice and slow. That very first sound you hear, those are called Korsakoff sounds. That's your systolic pressure. When the sound gets muffled and completely drops off, boom, you found the diastolic pressure. Looking at this, it really is this perfect synergy, isn't it? You've got this sphygmomanometer and the stethoscope teaming up seamlessly with the clinician's own sense of touch and hearing to lock in those vital signs. Now, here is a question that introduces a fun little plot twist into our clinical routine. We have 4 main assessment techniques, and there is a very strict standard order for using them. Well, except when we're assessing one very specific area of the body. Any guesses on what that exception is? If you guessed the abdomen, you hit the nail on the head. Normally, the sequence is inspection, palpation, percussion, and then auscultation. IPPA. But for the abdomen, we completely flip the script. It becomes inspection, auscultation, percussion, and palpation. Why? Well, think about it. If you were to start pressing or tapping on the belly right away, you could actually stir things up and alter the bowel sounds before you even get a chance to listen to them. It's a hugely important exception to keep in mind. Moving right along to Section 2, Technique 1, inspection. So, inspection is way more than just looking at someone. It's a highly active, multisensory process. You are deliberately firing up your vision, your sense of smell, and your hearing to check for normal conditions and, of course, any deviations. Across every single body system, you're on high alert for things like color, size, location, movement, symmetry, and even specific odors or sounds. Next up is Section 3, Technique 2, palpation. Since your hands are literally your diagnostic tools here, you've got to take care of them. Keep those fingernails short, and please make sure your hands are warm so you don't startle your patient. You'll use different parts of your hands depending on what you're checking. Oh, and always wear gloves when you're dealing with mucous membranes or body fluids. Also, a major golden rule: whatever you do, always palpate tender areas last. You want to keep the patient as comfortable as possible for as long as possible. Let's break down the 2 main styles of touch. Light palpation is exactly what it sounds like, using the absolute lightest touch possible to depress the skin just a ½ inch to 3/4 of an inch. That's for finding surface abnormalities. Deep palpation, on the other hand, means going on about 1½ to 2 inches with firm pressure. Sometimes you even have to stack one hand on top of the other. This is how you feel those internal organs and masses to check their size, shape, and mobility. Taking a look at light palpation in action here, you're really just using your finger pods to gently press the skin. Even at this super shallow depth, you're gathering a ton of data, assessing texture, tenderness, temperature, moisture, and elasticity. All right, on to Section 4, Technique 3, percussion. Percussion is all about using sharp, quick tapping to gather intel, and we've got 2 distinct ways to do it. Direct percussion is pretty straightforward. You're tapping directly on the body, mostly to see if an area is tender or painful. Indirect percussion, that's a bit more of an art form. You press the middle finger of your non-dominant hand firmly against the patient, keeping the rest of your fingers lifted, and then you tap that planted finger with your dominant hand. The sound that bounces back tells you if the organ underneath is solid or if it's filled with fluid or gas. It's like human sonar.
Now, when you're using direct percussion, especially on sensitive areas like the facial sinuses shown here, it is absolutely essential that you watch the patient's face closely for any signs of discomfort and explicitly ask them to tell you if they feel any pain.
Which brings us to Section 5, Technique 4, auscultation. This is where we rely heavily on the stethoscope to listen to the heart, lungs, and bowels. Let's do a quick anatomy check on this iconic tool. The ear tips need to fit snugly and should actually point forward toward your nose. To keep the sound quality crisp, the tubing really shouldn't be longer than about 15 inches. And down at the bottom, the chest piece has two parts, the flat diaphragm and the cupped bell.
Before you even place that stethoscope on a patient, let's run through some best practices. First, make sure the room is quiet. Second, and this is a biggie, always expose the skin. Listening through a hospital gown or bed sheets is just going to muffle the sound and add a bunch of fabric rustling. Third, do your patient a favor and warm the stethoscope head in your hand for a second. And finally, try closing your eyes. Seriously, it completely changes how you focus and helps you zero in on one specific sound at a time. Remember that chest piece we talked about? Here's the trick to using it. You want to press the diaphragm firmly against the skin. That's for picking up high-pitched sounds, like your standard S1 and S2 heartbeats. But the bell? You have to hold that super lightly to hear low-pitched sounds, like S3 or S4 heart sounds. Beware of a really common rookie mistake here. If you press the bell down too hard, the patient's skin stretches tightly underneath it and acts just like a diaphragm, completely blocking out the low-pitched sounds you're actually trying to find. Finally, we reach Section 6, documenting your findings. All of this amazing detective work means absolutely nothing if we don't write it down. Documentation is the true anchor of the patient's journey. Every visual, auditory, and tactile clue we just gathered has to be officially logged, because this record is what directs all of the patient's future care. Let's look at a real-world example here for a patient, Henry Gibson. You can see how his baseline vitals, like a temp of 37 degrees Celsius and a BP of 150/90, are systematically logged right next to the general survey notes about his appearance. Putting all these puzzle pieces together in one chart is what gives us the context we need to figure out what's really going on. To wrap this up, I want to leave you with this incredibly powerful thought directly from our source material. Remember that an abnormal value for one patient may be a normal value for another, which is why baseline values are so important. That really hits home, right? Every single patient's body is telling its own totally unique baseline story. So the next time you step into a clinic and pull out your toolkit, ask yourself, what is this specific patient's baseline story actually trying to tell me? Thanks so much for joining me on this explainer, and I'll see you next time.